Okay, let's start. Thank you very much for joining our workshop. This is a workshop about resilient health systems, which is an important topic in our evidence, our work for the state of health in the EU country profiles. My name is Ewout van Ginneken from the European Observatory on Health Systems and Policies, and I will be your co-chair today. If you don't know the state of health, which I'm sure you do know it, it's about making health system information, expertise and best practices easily accessible to policymakers and everyone who helps to shape policies. And later we will hear a little bit more about it. And it's a collaboration between the OECD, the European Commission and the European Observatory on Health Systems and Policies. So what we're doing in today's workshop is first, we look at our country profiles and see how we treat the subject of resilience there and what we can learn from that. And we would first have also a brief introduction from Federico Pratellesi from the European Commission about the cycle, the state of health in the EU cycle and how it works. Then Anna Maresso, you can also wave Anna, will talk about on behalf of OECD and the European Commission on how we have treated the concept of resilience in the current country profiles and the framework we use, and we can learn from that. And then in the second part, we have a panel discussion, which will be moderated by Giuseppe Figueras, the director of the European Observatory. And here we are addressing resilience, especially now during times of COVID, which of course is leading to a whole set of new questions. So all our organizations are thinking about how to deal with and how to address and change our frameworks. In that panel discussion, we will have again Federico talk about how the European Commission is dealing with that. Then we will have Guillaume Dédé from the OECD. Guillaume, maybe you can wave and talk about the work that OECD has been doing in this field since also COVID happened. And we have Anna Sagan of the Observatory, who will talk about our work from the European Observatory. And during all the sessions, you can please post all your questions in the chat, and we will try to answer them while we go. Let's then now start with the first part, and Federico, maybe you can introduce a little bit the state of health to the viewers. The floor is yours, Federico.
Yes, thank you, Ewout. Thanks a lot. So as Ewout just said, my name is Federico Pratellesi. I'm working as a policy officer in the DG, the European Commission dedicated to health and food safety in the Directorate for Health Systems. As Ewout said, my objective for this first short presentation is to provide you with some context to the discussion that we're going to have this afternoon. So I will therefore quickly go through the objective, structure and main deliverables of the State of Health in the EU project, just so that you get a sense of the options that we have at our disposal to revise the resilience assessment framework, which Anna will present in more detail in a few minutes. But first of all, so what is the state of health in the EU? As Ewout explained, the way we present it is that the state of health in the EU is an infrastructure to make health system information, expertise, and best practices easily accessible to policymakers and relevant stakeholders. So the rationale of the project is based on the realization that without access to timely and comparable health system information and data, health policymakers are sort of forced to operate in the dark, being unable to see the effects or just being able to see the partial effects of their policies, or prone to establishing erroneous cause-effect relationships between their interventions and changes in reality over time. So the experience of the COVID-19 pandemic is a testimony of this, having brought into focus just how badly governments need more robust and comparable information on health systems. So this has been sorely lacking in its most basic forms sometimes. For instance, simple counts of number of beds or ICU units and so on, and has been a large obstacle to setting up an effective response in several countries, also in the EU. At the same time, though, the reality is that in the health policy field, as we know, even during non-crisis times, policymakers are obliged to make decisions that are very often based on imperfect or incomplete information, which makes it very important then to have first-rate experts in the field, such as those from the OECD and Observatory, which are our partners in this project, support policymakers in their activities. And this is basically what the State of Health in the EU is about. The project started in 2016 under the Juncker Commission and is now basically a legacy that our Commissioner for Health, Kyriakides, has received to support our new policy agenda. So as you can see from this next slide, which you will see in a second, I think, the project is designed as a sort of two-year recurring cycle, starting every even year with the release of Health at a Glance, a reference publication which I'm sure most of you already know. So in addition to the chapters containing statistical indicators for 36 European countries, the first deliverables of the State of Health in the EU cycle usually include two thematic chapters, which in 2020, as Guillaume from the OECD will explain later in greater detail, are going to look into two topics of high relevance, of the highest relevance, I'd say, for the European Union. So the first one is an assessment of how resilient European countries have been to the COVID-19 crisis. And the second one relates to an estimation of the impact of air pollution on the health of European citizens. So the next milestone of the State of Health in the EU project consists in the publication of the country health profiles, which are designed to be a sort of standalone reference for knowledge and information on a country's health system, put into the perspective of a comparative analysis across the EU. So in 2019, we produced 30 profiles. And alongside these, we also published a so-called companion report, which is a working document by the Commission that sort of zooms in on a selection of topics of relevance to the Commission's agenda in the area of health. As you can see from the slide, we had 5 topics which tackled, among other things, vaccine hesitancy across the EU, the digital transformation of health promotion and disease prevention, skill mix innovations, and breaking down silos for effective, affordable medicines. So both the country health profiles and the companion report are published every odd year. So in November 2021, we will have the new versions. So lastly, the voluntary exchanges, this last circle, are an occasion for national policymakers to discuss with the authors of the profiles the findings and organize focused exchanges with them with a view to translate into practice the analytical insights that are presented into the analysis. So the time window for this extends to the first half of the second and final year of the cycle. So just to transition to the next presentation, let's quickly go back to the profiles and their structure. As you can see from the slide, each profile provides a short synthesis of the health status in the country, the determinants of health, focusing on risk factors and especially behavioral risk factors to health, but also looking at an account of the organization and governance of the health system, and a detailed analysis of each health system's effectiveness, accessibility, and resilience. So this analysis framework, the analysis framework of this last section of the profiles is going to be the focus of Anna's presentation. And that being said, I give the floor to Anna, and I thank you very much for your attention.
Thank you, Federico. Sorry, I'm just trying to share my screen. Can everybody see my screen?
It's perfect.
Yeah.
You can do presenter view if you like.
Let's see if we can do slideshow. Can you see slideshow?
Yes, it works.
Excellent. So thank you very much. As Ewout said, I'm Anna Moreto, and on behalf of the colleagues from all three organisations involved in the State of Health initiative, I'm really pleased to present the resilience framework that we've used in the country profiles. And as Federico said, the profiles have been published in 2 editions so far, in 2017 and in 2019. And we hope you're already familiar with them. I won't go through this slide in detail, just to say that as Federico set out the context, the profiles seek to respond to multiple objectives, and they have multiple audiences, but mainly policymakers in the member states, but also commission directorates and the wider public. And one of the key objectives is to outline the key strengths and challenges in the countries, but also on a comparative level. As Federico also highlighted, the template for the country profiles looks at various aspects of health in countries and health systems, and resilience sits very much in the assessment section here. All the template sections make use of evidence from a variety of sources, and you can see them on the right-hand side here. We have core indicators and supplementary indicators, as well as other sources of information, so that there's a mix of quantitative and qualitative evidence in the information base. Oh, sorry, I have a transition here, which we need to go through, right? So when we get to resilience, what do we define as resilience in the country profiles? Well, here it's called, it's the health system's capacity to adapt effectively to changing environments, sudden shocks or crises. So you'll note that this is a broad definition of resilience, and it covers not only shocks to health systems, for example, the impacts of the economic crisis that started in 2009 or 2008, 2009, but also epidemiological shocks such as the SARS outbreak in 2003, and indeed the current COVID-19 outbreak. But it also covers longer lasting challenges that can be foreseen and prepared for. 2 of the main ones being the health and social care needs of an aging population, and also the increasing numbers of patients that are suffering from multiple chronic conditions. So apart from those 2 things, the concept of resilience also needs to be context specific for countries, and we'll see a little bit more of that as we go through the rest of the slides. The definition also takes into account supply issues such as resource availabilities or resources available to the health system, and demand, that is disease patterns. So under resilience, we have 3 dimensions in the conceptual framework, and these are kind of roughly approximate to health system objectives. So the first dimension looks at how can a health system ensure long-term sustainability of resources. The second is, does it respond efficiently? And the third is, what are the mechanisms for strengthening governance? It's worth noting here that while the concept of resilient health systems did appear briefly in a 2014 communique by the European Commission, it was actually called a communication on effective, accessible and resilient health systems, there wasn't that much work being done on what this meant in terms of policy strategies or indicators. One notable exception was the work of Steve Thomas and colleagues, who published a paper in 2013 setting out a health system resilience framework in the context of the economic crisis, and using Ireland as a test case. So in 2016, when we were developing the template for the first editions of the country profiles, this was an opportunity to define in concrete terms what a resilient health system could consist of. And it's also important to remember that the primary focus was not an academic exercise at the time to develop a watertight theory of health system resilience. Rather, we had a very pragmatic objective, and that was what aspects of health systems could authors investigate under the assessment category of resilience. So these three dimensions of our framework seek to supply the content in terms of associated policy tools and measures to the concept of resilient health systems. This is a diagram that just seeks to give an overview of the resilience framework, and we'll explore each of these dimensions in the next few slides. But for each dimension, the template contains a comprehensive list of associated quantitative and qualitative indicators, as well as policy measures that the authors could explore to assess their particular country. In the country profiles, what you get is a discussion at the level of the chosen policy measures and indicators. So here are the green parts. In the diagram, you can also see that there are that these lists of policies and indicators can be clustered under various policy entry points. Here, they've been depicted in yellow. So, for example, these relate to health system functional areas, or as you can see for the governance dimension, it's based on some categories which combine health systems performance assessment instruments and some elements of the TAPIC governance framework, if some of you are aware of that framework. So a quick reminder here is that this current framework predates the onset of the coronavirus pandemic, as well as the new work on resilience that we in the State of Health in the EU project partners have been undertaking, and we'll hear more about that in the second part of the workshop. So let's take a look at the first dimension, sustainability of resources. So here, ensuring the long-term stability of resources refers to the capacity to protect or generate the necessary and adequate financial resources, as well as physical, human and information knowledge resources to address any upcoming major challenges. Here we list the main entry points and some of the policy measures or tools that authors can investigate. In the next slide, I'll show you a snapshot of the full list, but here's just a few of the main things. So under financial resources, we look at how health systems generate revenues, whether there's adequate diversification of funding sources. We look at the degree of stability of those resources, you know, whether there are financial reserves in place or counter-cyclical measures. And we also look at aging projections and other indicators of fiscal sustainability. Under physical resources, this is mainly on capital investments and R&D, the suitability of infrastructure for meeting the needs of the population. And this, I might draw your attention, includes resources for national emergency response plans or crisis preparedness measures. This dimension also covers human resources. So here we look at skill mix and other workforce information. For example, health workforce shortages, are there enough doctors or nurses? Aging profiles of doctors, whether there's a reliance on foreign workers, worker salaries and how they impact on retention, and workforce planning. And here is in the template, this is what authors have. This is a full list of core, supplementary and other qualitative indicators. I won't go through all this list, it's just to show you the full broadness of and comprehensiveness of these indicators. So turning now to the second dimension of health system resilience, this is about responding efficiently. And it refers to the ability to manage the health system with limited resources through achieving efficiencies, but while not sacrificing key priorities, benefits, access or entitlements. So the presence of sufficient resources, that was what we looked at in dimension number one, is necessary, but a health system that is able to withstand shocks to supply or demand must also be able to best use the resources that it has available. So this dimension focuses on mainly assessing existing inefficiencies in the health system, so the obvious structural issues that might be there, for example, the overuse of hospitals or the inappropriate use of medicines or high medicine prices. It also looks at policies examining the efforts to improve efficiency. So some examples here are the introduction of prescription guidelines or e-prescribing, more use of HTA, payment mechanisms that might incentivize efficiency or quality, whether there's any risk adjustment allocation measures in place, and also emphasis on care coordination. And again, we won't go through the list, but here is a snapshot of the full list of the indicators and policy tools for this dimension, and we'll see them a little bit more later on. So now we come to the third dimension. So strengthening governance refers to the capacity to steer the system in order to adapt it quickly to new objectives and priorities, and to respond to major challenges through a range of governance tools and strategies. So these are grouped under the following categories or policy entry points. So we look at the ability to formulate a long-term national health strategy or subnational health strategy for decentralized health systems. We also look at ensuring accountability and transparency. We look at promoting participation and engaging with stakeholders, as well as using evidence for health system monitoring and performance evaluation. And in all of these, the capacity to implement reforms or operationalize these tools is absolutely crucial. It's key. It's no point just having them listed or formally in a health system's plans. They need to be actually operationalized. And again, here is the snapshot of the full list of policy tools under strengthening governance, and you'll see that they're all qualitative indicators. So in the next 3 slides, we'd just like to present some of the results of an audit of the most common health system resilience strategies and challenges emerging from the analysis of the 30 country profiles that we published in November 2019. Some points to bear in mind before we look at this is that resilience is only one part of the assessment section, as we mentioned, along with effectiveness and accessibility. So in the limited space of the concise profiles, authors had to be selective in choosing the main resilience enhancing policies and challenges that they discuss. So the results shown here are illustrative rather than exhaustive, but nevertheless, we do think they're very instructive. Just to mention a little bit about the colour coding, the red here shows examples where countries have identified a resilience challenge without necessarily detailing any concrete response to address it yet. The blue shows that there are strains such as population aging or technological advances that are likely to impact on the longer term, but the risk isn't fully clear yet, or it hasn't been quantified. And the green shows examples where countries have identified issues and are actually implementing resilience enhancing policies in this area. Yellow just shows that these weren't discussed in that particular country profile, but it doesn't mean that the country isn't doing anything in this area. It just means that the author didn't choose to look at any of those issues. So under this first dimension, it's clear that many countries have identified financial sustainability of the health system as a major resilience challenge. You can see them all coded in red there. So this is a longer term resilience challenge that needs to be addressed to future-proof the health system and to ensure future adequate resourcing. But we can also see from this matrix that many countries are undertaking policies aimed at addressing health workforce shortages, for example, through a variety of policy measures. I don't know how well you can read that, but lots of the green ones there on the right-hand side. So these results highlight one of the assets of the profiles, in my opinion, and that's that they provide contextualized examples of resilience. So, for instance, the specific reason for doctor shortages could be the aging and retirement of GPs without enough graduate doctors coming through to replace them. Or it could be due to emigration of doctors abroad because of low pay or conditions at home. But therefore, the profiles can provide very specific country examples of the reasons for a resilience challenge and the different policy measures that have been put in place or would need to be put in place in response. So if we move on to the next snapshot, these are the results for the second dimension, responding efficiently. And you can see that there are a number of resilience enhancing policy measures that countries are implementing. These are all the green cells that you see in this matrix. They range from tackling the ways that hospitals operate and are paid, to containing the costs of pharmaceuticals through various pricing policies or incentivizing the prescribing of generics. There are policies here to increase the use of e-health and digital health tools, policies employing HTA to inform decision making on the benefit package, which goes in, or maybe what can be delisted, also on what's reimbursed. And also there's policies to strengthen primary care. So there's a wide range that you can see listed on the top row there. For the purposes of this presentation, the matrix shows these broader areas and highlights one example that we found of key challenges or strategies in the country, but there's more information in the actual country profiles. There might be more than one example, or there might be examples that can disaggregate further into topics and policies for a really granular understanding of what's going on. And as I said, I won't go into specific country examples, except to mention one. Here, a particularly interesting point arises when we look at Germany, because here for Germany, you see quite a lot of resilience enhancing policies, but you'll note that its high bed numbers and large hospital, some say overcapacity, would normally be seen as suboptimal from an efficiency standpoint, and thus it's been coded here as a resilience challenge in red. However, many have argued that in the light of the current COVID-19 outbreak, it's precisely Germany's high bed stock, both acute beds and ICU beds, that can accommodate an upsurge of patients if it's needed. That's an asset, and indeed has contributed to the health system's resilience. So these questions of hospital bed numbers have been hotly debated in German policy circles for some time now. And it's come to the fore again with the COVID crisis. So we don't have an answer to this, but I just wanted to bring this up because we need to consider such examples in our ongoing discussions on the resilience framework. What's a challenge and potentially a challenge, and what can be potentially resilience enhancing? Where do you draw the line? And this example also highlights how country context really matters in these kinds of analyses. And so here we come to the third and last dimension of resilience, and it's noteworthy that less is reported under governance measures. And this is partly because many of the profiles devote more time to the other two dimensions. But I would wager that if a country itself were to go through the full checklist of indicators from the template under this dimension, they would probably record a much fuller list of policy instruments that they have in place. But this dimension does remind us again, though, that in looking at strategies, national context is key. For example, in our framework, the existence of long-term national strategies or health plans is seen as a key resilience enhancing asset. However, as mentioned previously, implementation is absolutely crucial. So it's important to note here that there are country examples where such national plans exist formally on paper, but implementation is poor, for example, due to stakeholder resistance or other obstacles are encountered. For example, key elements of national plans are overruled by the courts, for example, as happened in Bulgaria a couple of years ago, when attempts to change its benefits basket, and they had a national strategy for this, was ruled unconstitutional by the highest court. So again, any analysis of health system resilience needs to take the specific contextual details into account. So I'm going to stop there with the results and just do one more slide to say, how can we already use this evidence? So apart from the academic exercise of developing a resilience framework even further, we feel that there's real value to policymakers. Countries can use their resilience-related findings to inform any health system performance assessment exercises and other initiatives that they have that are aimed at health systems strengthening. These findings can help steer national reform efforts in specific health sectors or in health system, or help with health system stewardship issues. And they can also feed into knowledge transfer or exchanges to discuss common resilience challenges and solutions with other countries. And as Federico mentioned, the State of Health in the EU voluntary exchanges are one such initiative that can help do that. So I'm going to stop there, and now we can, I'm going to go back to Ewout, and this shows you the slide, what the next part of the workshop is going to be about. So thank you very much, and over to you.
Thank you very much, Federico and Anna. I think that your discussion, and also you were alluding to it quite a few times already, Anna, the challenges that we have now in interpreting certain findings now that we have COVID around. And you know, the German bed hospitals is one very good example. We now will go over to Giuseppe Figueras, who will take us on a panel and discuss the work that's been done by the partner organizations and how we can improve in the future. Giuseppe, the floor is yours.
Thank you, Wout, and thank you very much, colleagues, for being here, for the excellent presentation, Anna, and for the participants online. Please stay, because we're going now for much more interaction, for much more feedback, and trying to clarify any confusion. This session is really everything you wanted to know about resilience and never dared or bothered to ask. So that's what it's really about. Resilience has been this sexy concept. Everyone, I mean, you open a newspaper, bloody resilience is there. The European Commission, the European Union is putting 690 billion, or 6,000, I mean, the numbers become so big at the moment, 6,000, I believe, billion on 680, not 1,000. I do like Joe Biden, right? I confuse the thousands with the hundreds. 680 billion on a recovery and resilience fund. And yet they're all smiling, but you guys had a hard time, even if you're all smiling to me, about agreeing what the heck resilience is and how we use it practically. And when a few years ago, the Commission bullied the OECD and the Observatory into saying, you have to use resilience, because we didn't like the idea, we did it, and now we're very happy, because as Anna showed, there's an awful lot we've been doing on resilience and thinking. Not that we got it totally right, almost right, but at least we got a few years ahead of the issue. So what is resilience? As Anna said, what it is resilience? And you guys, the participants, are practical as well as researchers. Researchers can be practical, actually, once in a while, but they're practical, pragmatic people that work on policy, you guys in EHMA, that run hospitals, health services. So the question to my panelists today, to ourselves, that are really experts, because we've been working on that for quite a while, is what is available? How can we use it? So how can we use this practically? What are the practical policy uses? What are the approaches to measurement? How we can compare with each other? And also we expect the participants to help us to contributing with suggestions, ideas, as we move forward to reform, to review this model that Anna has presented into the next generation of policy, of the next generation of profiles in which we're going to adopt resilience. And to do that, to make it a bit more complex for you and then to reach a strike clarity, we're going to hear additional initiatives that these three organizations, the European Commission, the OECD, and the Observatory, are working on resilience. And as I said, all those are complementing each other, and they're going to be converged into a new model to assess, measure, compare, and draw policy lessons to strengthen resilience in member states. So what we're going to do now, and I've been promised, so don't go away, please. I've been promised by my colleagues, they'll be very short and sharp. We'll have three, as I said, three additional contributions on the contribution of Anna. The first one is going to be by Federico Pratellesi from DG Santé. Santé, in addition to these country health profiles, has been doing a lot of work on data of resilience as well. In particular, there is the expert group on health systems performance assessment, which developed a report on resilience, which is going to be published very soon. And the three actually presentations are products that are going to be published very soon, almost simultaneously, one with the other. So Federico is going to tell us how this group came up with, what approach they took, what kinds of results they got, and all that in 7 minutes. Then we'll hear from the OECD and the European Observatory. Please, I have Anna Mareso, who's been offering to collect your contributions, your questions, your disagreements. I expect lots of our disagreements as well, and we'll bring them as we go along. So Anna will raise her hand once in a while and reflect your views and so on. So we like to have that as interactive as possible. Federico, thank you for being here. Thank you for leading this work on resilience and the country health profiles. I think I can say that on behalf of the OECD and the Observatory. It's been a really difficult but a very exciting ride with you to work on this subject. Federico, the floor is yours.
Thank you, Joseph. Thanks a lot. So as you've already stated, it happened that even prior to the onset of the COVID crisis, me and other colleagues in DG Santé, in their capacity as members of the expert group on health systems performance assessment, HSPA for short, had been working for a number of months already on how essentially we can conceptualize this notion of resilience in a way that makes it measurable and possibly subject to assessment, ideally quantitatively, but also qualitatively. So to this purpose, over the past months, we have been working on a report, which is going to be published very soon, which is titled Assessing the Resilience of Health Systems in Europe, an overview of the theory, current practice, and strategies for improvement. And I'll just briefly walk you through, I think, the main areas that may be of interest to the audience today. So the whole, basically the structure of the report is the one you see in the slides. So we start with a theoretical overview of the concept of resilience, and we try to somehow bring some clarity to what it means and how we could define it. Then after doing that, we delve into what countries are actually doing in this area and how they see the concept of resilience, how they conceptualize it, if they have used it at all in their current HSPA frameworks. Spoiler, not really. And then the third part, which draws largely on actually work from the European Observatory, tries to put these two things together, theory and practice together, by looking at possible strategies for improving resilience, as well as methods for assessment. If I can, yeah, perfect. So down to chapter 1. So basically the main takeaway from the first chapter, the theoretical overview, is that we show how the concept of resilience applied to health systems is still relatively new, having attracted, as Anna was saying, mass of critical attention in the research community only recently, I'd say even in the last 7-8 years. As a result, efforts that are aimed at defining the concept and as well as how it can be built, measured, assessed prospectively, not in hindsight, within such a complex entity as a health system, they're still scarce. You know, they're still relatively in their infancy. Moreover, also the research literature that we have found as we were going through the various academic resources on the topic do reveal that there is a not a consensus on the exact scope of the concept in and of itself, which may partly explain why we still use the term resilience to define some rather nebulous concept. So in an attempt to bring some clarity and additional input to the discussion, the group presented an overview of the descriptions of resilience from the scientific literature with the goal of really verifying, does it add any value to the health policy discourse, or is it just a buzzword? So the input from the members of the expert group and the review of the literature we have carried out allowed us to develop a working definition of resilience that is essentially consistent with most of the ones that are available, and to express what is the advantage of using this concept as opposed to other ideas such as, you know, robustness or other terms that may seem somewhat related to resilience. So despite the lack of maturity of this concept, our assessment of the contribution of resilience to the policy discourse is positive, because it has two advantages. So the first one is that it explicitly acknowledges that performance of a complex entity is contextual. So a health system may be performing very well given certain conditions. Whenever you take these out, then the health system is not going to be performing as well as before. So by thinking of resilience, that forces policymakers into thinking that that current results, as reflected in outcome measures or, you know, output measures, any kind of bottom line metric that tells you, yes, this health system is performing very well, is not carved in stone, is not systemic. It's very much context dependent. And the second advantage of this concept is that it presupposes that health system shocks are unpredictable by nature. You know, there's as we have seen over the course of the last months during the COVID pandemic, a lot of countries, I think actually the majority of countries in the EU, they did have crisis preparedness plans to respond to shocks of epidemiological nature, so to infectious disease outbreaks. The problem is that like the intensity of the outbreaks from COVID-19 was not foreseen. So, you know, there was a baseline that was dictated by previous infectious disease outbreaks, such as H1N1 and so on, which were of a magnitude not comparable to the one that was encountered this time round. So by nature, shocks are to some extent unpredictable, and using resilience as a concept allows you to think of it in this more comprehensive manner. So after the theory, we delve into the practice of what countries are doing, and that essentially boils down to having carried out a survey among members of the expert group. And the objective of the survey was essentially to find out the extent to which European health policymakers have operationalized resilience as a concept. And the results of the survey, unsurprisingly to some extent, show that the vast majority of health systems in Europe are yet to develop fully fledged concept of resilience and apply it to their health systems and to their performance assessment frameworks. So on the other hand, about half of the countries that we have surveyed report having framed at least some aspects of resilience as part of their HSPA processes. One interesting thing was that the scope and depth of these definitions of resilience was very, very different across countries in a pattern which, however, sees each country characterize the definition of resilience based on their history of traumas. Let's say if a country had a cyber attack that brought the health system to its knees, then you will see that country framing the idea of resilience in terms of cyber resilience. If another country had a bad experience had a crisis that stemmed from a climate event, for instance, you know, the famous textbook example is France 2003. There was a huge heat wave that created extreme pressure on the health system. So in that case, you will see that this country has developed a very thorough plan in response to possible future shocks of that specific nature. So this may tell us something about the value of exchanging best practices across country as a means to have health systems become more resilient. So another interesting thing that we found throughout our report was that we created a sort of typology of shocks. You can see on the horizontal axis, we defined environmental shocks, economic, societal, epidemiological, and so on, as well as resilience capacities. So we looked at the preventive capacity, the absorptive capacity, so the ability to absorb a shock after it has taken place, as well as to adapt and to transform to new circumstances. And we see that essentially there's a high concentration on only one type of a shock capacity combination, where about more than three-fourths of countries have reported looking into the preventive capacity, resilience capacity to epidemiological shocks. So if experience tells us anything, if this was the case, then you can only imagine what would have happened had another kind of shock occurred in Europe instead of an epidemiological one. So basically, what we've done also include beyond the surveys, that we have collected a number of case study examples, which give you a sense of how varied and heterogeneous resilience has been conceptualized throughout Europe. We see, for instance, Belgium having planned their health system resilience to disaster incidents such as terrorist attacks and so on in the wake of the 2016 terrorist attacks. Ireland has created a climate change adaptation plan for the health sector, and a lot of other examples, with an interesting trend that shows how most of the countries have at least framed their idea of resilience in terms of financial resilience. So having necessary buffers from a financial standpoint to withstand a financial shock. Then down to chapter 3, the report, as I said, aimed at combining theory and practice, and based on an account of a workshop that the observatory has carried out within the expert group, and additional research by the observatory. The chapter has explored what are the main preconditions for health systems to be assessed as resilient, as well as the operational obstacles that are impeding health systems from achieving them. So after having explored a set of strategies that you see on, I don't know if you can see it, but you will be able to see it from the slides after the meeting. We have, after having explored a set of strategies to improve resilience, the policy focus group that was steered by the observatory engaged in a discussion on how it should be measured prospectively. So at least partly due to the high variation in how resilience is defined, there was basically no agreement. However, there was a general consensus on the fact that at a minimum, metrics related to health systems capacity, for instance, bed occupancy rates, number of beds, and so on, the ability to quickly mobilize resources, both physical, financial, human, health workforce, and the adequacy of supply chains would constitute the bedrock of any kind of meaningful indicator set. The second conclusion was that this indicator set would necessarily have to consist of a mix of quantitative and qualitative measures. And the final one was that tracking selected relevant indicators over time and interpreting them correctly may be more important than seeking for some kind of holy grail metric for health system resilience, which tells us that realistically speaking, we'll have to keep on relying on suboptimal measures and trying to make sense of the complex web of imperfect metrics that we have at our disposal. This gave way to four different ideas for improving ways to assess and measure resilience. The one relates to developing new measures to assess governance capacity. And this is based on the observation that whatever the conceptualization of resilience was in any country, all countries basically agreed on the following: that effective governance constitutes the essential precondition for all other material, let's say, drivers of health system resilience to realize their potential. And although this is difficult to assess from a quantitative standpoint, developing a solid assessment framework for assessing health system governance capacity may be relatively more feasible in the short term compared to just building a huge health system resilience framework. And also another interesting takeaway was that the obstacles in the area of governance that then turn out to be resilience inhibiting factors, let's say, are oftentimes detectable not only during crisis times,
Federico,
but also, yeah.
Federico, sorry to interrupt you. We are running out of time. We are twice.
Oh, sorry.
I mean,
I'll speed up.
I understand it's very unfair to ask you what is a really rich and in-depth analysis in 7 minutes, but we need to hear a lot from the participants as well.
Absolutely,
so
yeah.
Wrap it up, please. Sorry. Thank you, Federico.
Yeah, sorry. So basically, the idea is that since governance related problems can be detectable also during non-crisis times, then it would be worth investigating the governance capacity with an indicator set. Then the other one, the second conclusion relates to extending the scope for measurement of health system resilience beyond the areas that we usually cover, as Anna has explained in her framework. The third one relates to extrapolating relevant insights from past failures and experiences. As we have already explained, countries that have had a crisis happen to be able to strengthen the resilience capacity specific to that crisis. So there's a huge value in exchanging experiences and trying to come up with a sort of a dictionary of best practices to make health systems more resilient. And finally, the fourth takeaway is that there needs to be better communication tools to make resilience matter to policymakers. And this is based on the assumption that during non-crisis times, resilience becomes less important to the eyes of policymakers. But then, as we see, when a crisis hits, this is all we talk about. So sorry again for running long.
Okay,
and
thanks very much. Guillaume and Anna are going to be very generous. I'm going to be very, very short and compensate for your time. Federico, that was really, really good stuff. Really, really useful. But I'm a bit worried because no one is asking questions, contributing, disagreeing, which I don't believe it. Because are we all buying this? Are we all buying what our colleagues, not only Federico, has said, and now Guillaume and Anna are going to say? does really resilience add much to a good performance system? If a good system, if a good system is strong, if a system is strong, apologies, and performs well, what is this additional value of being resilient? Do we buy this idea of the shock? Clearly, you said as well, the context is extremely important. Matters an awful lot. Context always matters, but in resilience even more. You made that point very effectively. You made the point very effectively as well that even those countries that were had preparedness and preventive measures were not doing that terribly well. In fact, as you know, the index of preparedness for pandemics from the UK and the US were the highest in the world. And one cannot say that these two countries have done that terribly well. So what's happening there? So just keep that question for later, as I'm sure other questions will come from the board. And an important issue in which Guillaume and Anna will agree is that governance, the ability to transform, to quickly adapt, is a fundamental element of resilience. So lots of very important points that are coming together here. Guillaume, you and Anna will have to go to 7 minutes, otherwise we'll not be able to have the contributions. Very unfair, I know, but otherwise we'll not have the contributions from the audience who have lots of things to say. Guillaume.
Thank you so much, Josep, and I will of course do my best to keep. I will keep my 7 minutes. There is no point here. Basically, yeah, I will just present you very briefly the main elements that come out from the next report that we're publishing in collaboration with the European Commission as part of the State of Health in the EU cycle that Federico described at the beginning. And we try to address the question in one of the thematic chapters of Health at a Glance, Europe 2020, is how resilient have European health systems been to the COVID-19 crisis? The interesting thing is that even the phrasing of the question is interesting in the sense that we didn't say, have European countries been resilient? Because there is no possibility to answer to such question. And as Federico just alluded to in his presentation, is that it's a process, it's a rather very moving topic and subject, so it's extremely difficult to come up with something very authoritative on this matter. So we have made an attempt in this chapter, which is rather long, rather comprehensive, to give some possible approach to this question in the context of the crisis that we've been through, hoping that it will contribute to the discussions around the management of the crisis, and more broadly on the issue and the discussion around the concept of resilience. But it's really just an attempt from our side to use this framework of analysis to report back on what has happened and what we found out by reviewing the situation in countries. So basically the outline of this chapter is the following. We first describe, of course, because it's necessary, what has been the impact of COVID-19 in European countries, showing that there has been difference across countries, and that it's probably there are things that we can try to analyze or to describe that could explain in part some of these differences. Then, of course, we go under important elements or policy measures that were taken, of the containment and mitigation strategies that were enforced at the very beginning. Then, of course, the way countries have managed to cope with the surge in demand, be it from a human resource standpoint or capacity, a more general capacity standpoint. Of course, then we try to address also other aspects that are also relevant to this idea. It's just like also the ability to maintain care during the surge in demands, and also the importance to address some specific vulnerable population that also are, considerably and disproportionately affected by the crisis. So I will go very quickly because we don't have the time, and just give you just maybe stop on few indicators that we report. For instance, I like this one, which is on the impact of the crisis in European countries. What you have in blue, the plain graph is the reported deaths in Europe, officially recorded as COVID, and the line is the excess deaths. And what we see here is that obviously during the first wave, and please just pay attention to the left-hand side of this graph, because after it's a bit more tricky to analyze. But what we clearly see is that there is huge difference between what has actually been reported by countries and what was measured as excess deaths. And this is probably related to the fact that at the very beginning, there was some sort of a consideration stage for a situation that was brand new, with countries that were not ready necessarily to record and not able to record properly, to test properly all the patients that were dying, I mean, to have provided them with tests before they died and so on. So we see that this is just an example of the fact that this was really a sudden shock, something that has affected countries and that could not, which could not necessarily cope with it at the very beginning. Then if I move on a bit on the containment and mitigation strategies, the idea for us was to see how countries have managed to try to reduce the burden of this disease, to contain the spread of the epidemic, the different policy options that have been enforced and so on, to try to buffer a bit to receive this crisis and reduce a bit its impact. So we describe in the report all the different measures that were taken with the timing that was used and so on. So of course we had to categorize them, but the nuances and the differences are a bit more fuzzy than that. But for the sake of clarity, we have grouped them under 3 categories. What were the physical distancing measures, the improved personal hygiene measures, and of course the testing and tracking policies. A very interesting thing is that we see that some countries also, because of this situation, of this sudden situation and the novelty of it, had issues to, and were not necessarily ready at the same level or at the same capability to answer to the surge demand in testing and cope with the increased number and follow with the increased number of cases. We see that countries that are on the left-hand side of this graph, which represents the number of tests that were performed per 1,000 population in the first months of after there has been noticed, I would say, transmission, a dynamic of transmission inside the country. We see that some countries had already the capacity to test in a sufficient fashion, and some others had much more difficulties, and the ratio is between the best performers and the worst performers is extremely, extremely high. So not all countries were ready the same way to cope with this. And then we try to also go a bit further in analyzing how effective these measures have been. And also we see that, not all countries have been able to control the epidemic, meaning reducing the transmission number, bring it below 1, the reproduction number. Some countries managed this rather quickly. Some others took almost 2 months to do it. And this has, of course, plenty of explanations. And of course, some that are much beyond the hands of the government and the will of the government. But we see also still that some early targeted measures tend to have a greater impact, and countries that had the opportunity and had the chance, if I may say so, to take early measures on because they were affected or impacted later by the pandemic, did better in the management of this of the first wave. But then once the shock is here, that the country tries to absorb that, then another pillar of resilience that we mentioned is, of course, the ability to answer to this surge in demand and to cope with this increased demand. And here, of course, in the report we describe the different pillars, so the health system, the capacity, the health workforce, the health capacity, and so on. We see that all countries didn't start from the same point. Some countries have a higher number of health professionals than the EU average. Some are running shortages for quite some times. And we see that this had necessarily an impact. But apart from that, we saw also that a lot of countries managed to find very astucious means to increase their health workforce capacity. And this is also something that was constant. So the resilience was showed in the creativity countries had to find solution here. And this applies also when we look at the physical capacity of the system, the number of beds in ICU and so on. We know that during the first crisis, the capacity of countries was not reached, even those the most affected ones, because countries managed also to find solutions to create new beds, to transform new ICU beds, to transform old wards, normal wards into ICU wards and so on, to transfer patients from regions and so on. And what we see is that actually what has been the main constraint here was more the ability to populate these new hospitals, these new beds, rather than actually creating them physically. So this is also a means to show that the resilience was here, and in a very, also, as I mentioned, a very creative way. I will pass on this aspect of health inequalities and so on, but it is very important also to keep this in mind because the resilience is also measured as the ability to remain inclusive and to look after also the most vulnerable of the parts of the population. And we know that in the context of the COVID-19, this disease affected disproportionately some segments of the population, obviously the elderly, but also, of course, more vulnerable tranches of the population, like people on low income or homeless persons and so on, or marginalized groups. But one of the elements, one of the pillars of the resilience is also the ability to provide care, to continue to provide care to patients that are not necessarily affected by the ongoing crisis. And we'll see that on that specific aspect, it has been much more difficult for countries at the very beginning of the crisis to maintain decent access to care and for other health issues that were not related to the ongoing crisis. It's getting a bit better right now because the countries have learned on that. So that's also an aspect of resilience, the ability, to learn and to not reproduce necessarily the same errors. But what we saw this was one of the aspects on which European health systems did not manage to cope with. And that's a very important thing to keep in mind for future reflections around this issue. And I'll just finish with one of the main insights from the work we've done. A summary of this report is just basically what we need, and even more today than before, is a stronger health system, but more particularly for primary care. Of course, the focus has been very much on ICU, on the hospital capacity and so on. But saying that we need more hospitals because of this crisis would be to say that we need more oncologists to treat better cancer. That's really not the way to answer to this question, because actually to be able to cope better to this requires to have a better primary care infrastructure to be able to spot early on the signals, to treat the patients early on, to dispatch them correctly in the health system and so on. So this is, and of course, to deliver the needed care that for non-COVID patients, so the permanence of care. So this is very important, one of the main output of this report. What we know also is that the quicker you're able to act and to decide, and we come to the idea of governance that you mentioned, the quicker and the flatter the hierarchy is in the decision-making process, the better, because what matters in these situations is to be very, very fast and to swiftly and precisely answer to very early on to the signals you receive. Of course, another important element is that the stronger the focus will be on the vulnerable populations of your system, the stronger your system overall will be. The health system is strong in its ability to look after the weakest parts of our societies, and that's also even more true in the context of crisis. And of course, resilience and building more resilient health systems will require further works like the one we've done, analysis, comparisons, discussions, disseminations of this work, because that's by learning by the others' actions, peer reviews of actions and better coordinated policies at the European level that will make overall our systems stronger and more resilient to future crises. So if you're interested in that topic, and I'm sure you all are, I'm just advertising that we are releasing the content of this presentation, the full chapter that will be part of Health at a Glance on Thursday this week, and we'll have a very interesting launch webinar as well with high-level stakeholders and key stakeholders and key opinion leaders also commenting on this aspect. So if you stay tuned, because the discussions will continue, of course, on Thursday and much beyond in the months that will come, because this topic, as you all know, will be central in the future discussion around health systems. I'll stop it here. I think I've managed to keep my 7 minutes, Josep. I hope so. And I pass it over to you. Thank you.
Josep, you're muted.
Saying, Guillaume, that it was 15, it wasn't 7, but anyway, like for Federico, I do appreciate how complex it is to present the enormous amount of work you have done. So I don't know, Anna, I have to be strict with you because you're working with me, so you have to stick to the 7 minutes. The good news, colleagues, though, is both. These slides will be available to you. Number two, these products are being launched as we speak. So we heard already from Guillaume, we heard already from Federico. Third, you perhaps don't see it now yet, but the clarity will strike you, I assure you, and you'll see that actually the messages do echo very much with each other. Fourth, you'll see as well that this is really, you're getting a really intensive course on resilience, and the best that is there now coming with the observatory as well on the material of resilience. Very important points there, Guillaume. Search capacity, search, flexibility, a bit the same messages we got from Federico. This search capacity, still the problem, Guillaume, and as a question I'd like to ask you for later is, we don't know the causality yet. We kind of say, yeah, you know, if we manage to have a systems approach, if we manage to do this search quick capacity, should go better, but still there are very puzzling data and information and impact there that we still don't fully understand. But one point that we all agree as well is the vulnerable population. And it has happened in every single crisis. The refugee crisis, the financial crisis, the vulnerable always paid the price. So focusing on these populations is fundamental. Anna, tell us all the stuff of the observatory, more materials there, materials that the participants will be able to access. And then our other Anna will summarize the questions from our participants. Go ahead, Anna Sagan.
Thank you, Josep.
Anna Sagan was from the observatory, is a research fellow within the observatory.
Good afternoon, everyone. Just before I start, it's really fascinating to hear the presentations by Federico and Guillaume, and to see how much overlap there is between the work that EC and OECD and us, Observatory, are doing. And really fascinating to see how pretty much independently of each other, we kind of managed to, in the end, arrive at similar findings. So perhaps, you know, the question should be, how do we help the policymakers make sense of all this growing vast body of evidence where, you know, there are different organizations doing similar things, arriving at similar findings? Perhaps a question for us here would be to kind of ask ourselves, how can we better collaborate on this and other issues? And it seems like the state of health in the EU provides is a big opportunity to achieve that. Anyhow, I'm going to move on to my presentation now. Anna, thank you for sharing my slides. Today, during my presentation, I will mainly focus on introducing our resilience brief. But I will also, if there is time, try to introduce other resources that we at the Observatory have been developing in response to the COVID-19 pandemic that can potentially feed into improving the way that the state of health in the EU profiles report on resilience in their next edition in 2021. So beyond working on the profiles, on these profiles, Observatory separately has had a long-standing interest in studying health systems resilience. And formally, we started this independent strand of work about 2 years ago with colleagues from Trinity College Dublin. And you can see the result of this work on the screen, which is a conceptual policy brief on resilience. And the emergence of the COVID-19 crisis at the end of 2019 has really provided a key momentum for us to first finish this work, and then a big impetus for further work in this area. So on top of this slide, you can see the definition of resilience that we use in our policy brief. And for operational reason, it is a narrower definition than the one that is adopted in the state of health profiles. And so we, as actually Federico did part of my work here, because you're using a similar definition as well. So just to tell you, in the policy brief, we understand health system resilience as the health system's ability to prepare, manage, and learn from shocks. And I will explain in a minute what these mean, but first, I just wanted to explain what we mean by shock. And we understand shocks to be sudden and extreme disturbances such as epidemics, natural disasters, financial crisis. And this is very much distinct from more chronic strains. I think in the profiles Anna mentioned, they call changing environments. So strains such as those caused by population aging that are analyzed in the state of health profiles, but these are things we do not focus on in the brief. And we think of shock in a dynamic way, which is a cycle that consists of 4 stages that feed into each other nicely in a loop. But of course, in real life, this is maybe quite different and more complex, as we have seen with the COVID crisis. So just to walk you through the cycle, which you can see here in the colorful picture in the center of the screen. The first stage, preparedness, which is the green cycle, is related to how vulnerable a system is to various disturbances. And in this stage, the system needs to get ready for shocks before they actually happen and identify some optimal responses. But of course, actually experiencing a shock is not necessary for a system to be resilient. And a resilient health system may be one that is prepared for a shock, but this shock might actually not necessarily happen. In stage 2, which is the yellow stage, the focus is on identifying the start and type of the shock, which took us a little bit of time with COVID, perhaps. And the earlier we realize that the shock is happening, the faster and more effective our response can be. And this can be achieved through having comprehensive surveillance and monitoring early warning systems. Then stage 3 in red is when we're actually managing the shock. So the shock is already here. The system absorbs the shock, as Federico explained, when necessary or as necessary, adapts and or even more profoundly transforms to ensure that health systems goals are still achieved. And this is the traditional focus on resilience work in the literature so far. So from the perspective of health systems performance, resilience, also as shown by Federico, goes beyond how a system bounces back to where it was before, you can see in his picture, but also how it transforms and evolves into, ideally, a better state. So there are elements of health systems strengthening in there as well. And finally, the last phase is the recovery stage, where there's a return to some kind of normality, but there might still be changes as a legacy of the shock. And then you can see in the diagram that the recovery from a shock, which is the stage 4, feeds into preparedness for the next shock cycle as we go through the loop again. And then next slide, Anna, please. Thank you. So we use this framework to identify strategies for enhancing resilience. And we have identified 13 such strategies. And you can see them on the gray arrows on the picture on the left-hand side. And as you can see, and these are the same strategies that Federico has shown before. So these strategies are quite general and are meant to be applicable to any acute shock. We have drawn them from the literature on the past shocks, including the financial crisis, SARS, Ebola, Zika outbreaks, the Syrian refugee crisis, other political crises. And we have also drawn, with the brief published earlier this year, we have also drawn on the emerging evidence from the COVID pandemic to sort of validate this list. And as you can see, we have mapped these strategies onto the 4 stages of the shock cycle that I have just described. We have also mapped them on the health system functions, which you can see in the horizontal categories, which are governance, financing, resources, and service delivery. And of course, there will be many overlaps between both the stages of the shock cycle and the functions. For each of these strategies, we also attempt to identify assessment areas, which you can see on the right-hand side, an example for governance strategies. And these assessment areas have mainly been drawn from a rapid review of indicators. These has already been said before by Anna. Some of these indicators will be quantifiable, such as numbers of doctors and nurses, but many will be qualitative. What is important is that, as been already said, that not all metrics are always appropriate, and both their selection and interpretation will depend on various factors, including when we do the analysis. So, for example, resilience can be assessed after the crisis, providing an evaluation of the handling of a specific crisis, but it can also be done prospectively and regularly to establish potential sources of vulnerability, which is what a state of health in the EU provides attempt to do. So the challenge with
Anna,
yeah.
Sorry, you still got 80 slides to go and you're already on 10 minutes. So now you have to wrap up, otherwise there'll not be many possibilities for colleagues to question.
Okay.
Sorry about that, Anna, but we all been really late today.
Okay, so let me just quickly walk you through the next slide. Thank you, Anna. So here you can see the policy brief that we are currently working on. So it applies our conceptual framework that I just described to analyzing resilience to the COVID-19 crisis specifically. So we look at just one shock as opposed to all the others. So we take the list of strategies that we have developed in the conceptual brief, and we audit them one by one based on the lessons from the pandemic so far. And the goal is to come up with a new list that is more granular and specific strictly to COVID-19. So this is meant to be a living brief, which means that it will be reviewed and likely revised as more evidence emerges. I think perhaps next slide, let me just quickly show you what else we've been doing. So this is one of the major products that we have developed during the COVID pandemic. This is a platform called COVID-19 Health Systems Response Monitor. It was launched in early April, and the purpose is to gather evidence on national responses to the pandemic across the WHO European region. And this is done systematically following a common template. You can, Anna, if you click to the next slide, you can see example from France, and it's organized for every country. It's organized according to health systems or building blocks that are of relevance to the pandemic. Then next slide, perhaps. So this is another source of information that we have prepared, and this came out a few weeks ago. It's a special issue of our quarterly publication, EuroHealth. It's a hefty 100+ page volume, including our article on resilience, which is a prelude to the brief I just mentioned. But it also includes many thematic articles that have bearing on resilience and can inform the state of health profiles. Next slide. This is also an ongoing work which will be published early next year. It's a special issue of the Health Policy Journal with thematic and cross-country papers. And final slide, I think. And finally, this is like our latest addition to the to the pool of COVID products is a series of webinars that focus on various aspects of the COVID response and offers spotlights on country experiences with an interactive element. I think I should stop now.
Thank you, Anna. I'm so sorry to cut you. You were the last one and you paid the price for everybody, such as life. It's a bit unfair, Anna, because you put a range, because it's the observatory, I'm from the observatory, I'm biased, but also because there's a number of products that would be very useful for our colleagues together with the products, excellent products of the OECD and the Commission, and because they do complement each other, the health policy issue, the EuroHealth, the continuous monitoring we have on the web with the European Commission and the WHO of COVID responses and resilience. So this is important resources. Even if I've been a lousy chair, not allowed a lot of debate, at least the participants today can have everything they want over resilience if they want to go in more detail. So Ana Mareso, can you summarize the questions and the views from the audience? And then I'll ask the discipline that I haven't managed to impose on my panelists and respond 1 minute each. I'm choosing some of these questions. And if you don't answer me one question, I answer myself. So Ana Mareso first, summarize what's been said by our colleagues, and then I'll give 1 minute each, starting with Federico first, followed by Guillaume and Ana on reflecting on what our participants are telling us. Ana Mareso.
So we have a few questions. I'll just try and group them. One question is about, given that the definition of resilience is so little known, how were the indicators developed? Like what methodology was used? And when it comes to the conceptual framework, using these conceptual frameworks on resilience in practice, were stakeholders involved in developing the indicators? So that's one sort of set of questions from Ellie Briefveld. Another question is specifically for you, Federico. We don't have the questioner's name, but it says, do you think it's possible to have a dictionary of best practices that can be respected by all EU countries when taking into consideration the differences between them? So the idea is you can have a resilience framework, but can you go further and just have a sort of a best practice dictionary? We have another comment by Brian Cohen, who says that organizing surge capacity sounds logical, but what are the key ingredients to make that possible without tying up resources indefinitely? So how do you organize surge capacity without impacting on, you know, the day-to-day that you need to get on with in providing health services? And one last, and then we have, I'm just scrolling through, sorry, regarding to, we have one more question about hospital capacity, and that's for Nirmala Sari. If you send us your email address, Nirmala, we can email you because your question is a little bit more complicated. So those are the questions that have come through.
Thank you very much, Anna. You could yourself answer many of those, but we'll ask the panelists now to respond. I will start with Federico. Federico, this list of best practices, we want the Commission to lead us, to give us best practices. So could you do that, Federico?
No. No, thanks again for the question. I think that what I was trying to hint to in my explanation was not a one-to-one transcription of one best practice from one country that has proven successful in tackling a specific shock to the others. But I think that there is a value inherent to collecting this. Perhaps dictionary was a bad wording. But I think a collection of best practices that can be used as a reference book by policymakers in the health sphere that are trying to make their health systems more resilient to an array of shocks, bearing always in mind that there is a degree of unpredictability that makes preparation to shock-specific episodes very difficult to achieve. So I think in the bottom line is there's a value in trying to build a dictionary of best practices, but the objective is not to just have a one-to-one transposition of them all over the EU.
Yeah. So the EU always doesn't want to be normative, believes in subsidiarity, but the EU, Federico, and we are really proud to work with you, has good collection of best practices exchanges and many ways in which, many platforms in which you put the countries working together on learning about these best practices, but never been a dictionary, may never be normative. So thank you for that. Guillaume, and I'll leave the more difficult question for you, Anna. Guillaume, can you tell us a little bit on the indicators, not details on the development, we don't have time for that, but how much, all of you could respond like that, we've all been involved in developing indicators. Guillaume, but how much we've been consulting with the stakeholders in developing those indicators? EHMA, European Management Association, is very sensitive to that because they're individuals, managers that are running the systems, have a good detailed understanding of managing, of policy implementation, and perhaps feel that these indicators does not relate. Some of them, I'm overreading that, those indicate on what doesn't reflect what they really need. Guillaume.
Well, thanks, Josep. Yeah, actually, it's been a very difficult process. I mean, it's a moving target. We have started to work on this report in the case of the report I presented in late May, let's say. So when we're just phasing out from the first crisis, from the first wave, then we worked on it over the summer. Now we are finalizing, we're circulating it, and we are hit by the second one. We have tried as much. What I'm just trying to say here is that countries were busy with something else rather than answering our questions and our methodological inputs and so on. So we have consulted them in a couple of instances through our working parties on health statistics and so on. And I think that it will be very helpful in the future to feed in, to collect new metrics, new information that will be useful to better measure and assess, the ability to perform in context of crisis, to cope with the surge in demand and so on. But the indicators we have right now, we've pretty much, used what we had and what we thought could be a good alternative, but that's really work in progress and nothing is really crafted in stone here. As I said, I hope that in the next months we'll be able to have more in-depth discussion with countries on what to pick up, what to discard, and so on. But for the first part, unfortunately, we were really running out of time, and we had to work mainly with what we had and what we internally thought were the best. And
we've been very sensitive not to overload our member states who have to manage the crisis. But I think I speak in your behalf, Guillaume, of the OECD, the European Commission, and certainly the Observatory, that we will be very keen, genuinely keen, to have your feedback as we develop the new template to measure, assess, and learn from resilience for the new set of country health profiles. So watch this space. We'll be consulting you, we'll be consulting the member states, because this is a core development. Anna, as I said, the difficult question for you, they're all difficult really. Can you have this search capacity and at the same time maintain good health services? Can you have this good performance, what I was asking Guillaume earlier, of the health system and Federico, and at the same time have this search capacity? Can have you both? Can you have the cake and eat it?
That is a very difficult question indeed.
I told you.
Well, if you look at countries across the globe, in Europe, but also across the globe, how they have dealt with the pandemic, it is possible. There are countries that have done very well during the pandemic, and many of them are outside of Europe. So there is learning for us to be done, but also in Europe, some countries have fared better. So the quick question, it is possible. It is maybe a matter of where we learn from. So for example, when the pandemic struck, I kind of have a feeling that a lot of the countries have looked other neighbors in Europe for the best lessons, whereas some of the best lessons have actually been outside of the region, and they were in countries sometimes poorer than European countries, for example, Vietnam, in countries in East Asia and elsewhere that actually managed to avoid having a pandemic pretty much. So, you know, it is possible, you know, there is learning to be done, and then we should not be Eurocentric. We should look for the best lessons everywhere, especially to countries that have dealt with similar crises in the past, such as SARS.
What happens, Anna, is the other day I was in a conference highlighting how good was South Korea, how they managed, how their preparedness was ideal. And now you look at the data and it's one of the countries with lots of problems as well. So we really need to learn. Let me conclude very, very quickly by saying thank you for your patience, participants. I am sorry we talked too much at this end, but really there's a lot of meat we have on the table. There is a lot of consistent analysis and rigor that we could not but offer to you. The organizers will put the slides, I've been told. If not, Anna Mareso, please help us to remind them, all Annas, both Annas, that they have these slides available. Please look at these products are available. Please don't reinvent the wheel. We're now coming together to come up with a common definition. You saw the definition was the same one, really, very important. We are coming together with the measures, and we are coming together with the learnings and the lessons between these three large organizations. And I think, in spite of the wishy-washy of resilience, as I felt it was a number of years ago, we begin to understand the value, the contribution, the practicality that our EHMA colleagues, participants want always in our sessions on using resilience as a way to strengthen and improve the search capacity of health systems, not only with COVID, which is a sexy thing, but as Federico was saying beautifully, with many other shocks that come up, as Anna was saying, into the health system. So watch this space, we'll keep working on that. Please come back to us, shout, tell us, reflect, criticize, contribute, disagree, agree with this work, because we're really keen and open to your contributions and feedback. Thank you very much, and apologies for the delay in this session. Thank you. Have a nice day. Bye-bye.
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 Bye.